to mute myself.
Okay. Good morning, friends. Welcome back to Saturday Club of Baroda morning meeting. Sorry for little delay due to technical glitch. It's a pleasure to introduce Dr. Vishwanath Kulkarni. He's a consultant pediatric neurology and epilepsy at Pune. He's MD Pediatrics and an IEP fellowship in pediatric neurology. Currently, he is affiliated with DY Patil Hospital and Research Center, Pune, several other hospitals in the city. He is an ex-surgeon lieutenant commander, Indian Navy. He has several publications and awards to his credit. He is founder secretary of Maharashtra Academy of Pediatric Neurology. And he is going to talk about genetics and precision therapy in pediatric neurology. Actually, I heard him at the Pentagon at Hyderabad, and I was very impressed with the kind of detail that he said. I thought let us have him to share the same thing with our Baroda meeting audience. And along with him, we have Dr. Sridhar Joshi, who has been our guest speaker in the past. He's a pediatric neurologist trained in CMC Vellore, and he will be there as a lead discussion. So over to you, Dr. Vishwanath. Thank you for accepting.
Good morning, all. At the outset, I would like to thank organizers and Dr. Panda sir for giving me this opportunity to talk in front of this August gathering in the Saturday Club of Baroda. So today I will be talking about the precision therapy in pediatric neurology and epilepsy. So we know that we have evolved over the period of time, and now it's the era of artificial intelligence. Then why should medicine, lag behind? As we know, there are 4 P's in the medicine. One is the preventive medicine, one is prognosticating medicine, third one is the predictive medicine, and the fourth and the most important being the precision medicine. So the past was all about intuitive medicine, which was, composed of signs, symptoms. Present is of evidence-based medicine, which is all about clinical trials. And future and today is all about precision medicine, that is all about algorithms. Now, here I want to mention one thing very clearly, that history and impeccable clinical examination is the cornerstone of each and every examination and reach to the diagnosis. The common things are commonly correct in clinical medicine that we know. But as Dr. Joshi sir pointed out yesterday on the group, that कुछ नहीं हो सकता से लेके बहुत कुछ हो सकता है. And to tell this, I am here in front of you. So, coming to what is precision therapy, it is the individualized approach that targets the underlying cause of epilepsy and neurological disorders using genetic, biochemical, and phenotypic data. So we know this particular picture from the ancient Mahabharata, that the Arjuna could see the eye of the parrot. If just a small, here the hypothetical situation, the Arjuna could see the eye of the parrot, but if the Karna would have got the chance, what he would have seen? He would have seen his arrow into the eye of that bird. So let's be like Karna and go for the precision medicine. So precision medicine is right diagnosis, plus right treatment, plus right time. So early gene testing can stop a cascade of disabilities the parents, the children, they undergo. Some epilepsies one thought untreatable, now they have the targeted drugs for the same. And it obviously avoids polypharmacy, minimizes adverse effects, and improves outcome. Now, as I was from Indian Armed Forces, Indian Navy, there was one saying that ek goli or ek dushman. So you should be precise about your diagnosis that you can use the targeted drug for the same. Now, when I put this slide, what does this diagnostic odyssey means? It is the term used to describe the long and arduous journey that many rare disease patients find themselves on the pursuit of the diagnosis. So if you see this European data portal, so almost 41% of the rare diseases are misdiagnosed at least once. Out of them, 75% of the rare diseases, they affect the children. And 80% of the rare diseases are genetic in origin. And what it leads to? It leads to disease progression, delayed treatment opportunities, financial burden on the parents, on the family, and it obviously affects and impact on the quality of life of that particular family. So what are the four main pillars of the precision therapy? So it is number one, etiology directed. If we know the etiology of the particular disease, for example, it is tuberous sclerosis, we are having everolimus for the same. Second one is the mechanism directed. Now, when I talk about mechanism targeted, it means so if the mutation cause gain or loss of function. Now, this particular term is very important. So, what does gain of function and loss of function mean? So, whenever there is mutation of the particular gene, it expresses excessively that particular protein, which means the gain of function mutation. And when it impacts the protein formation, it is formed on the lower side, then it is called loss of function. So for that, we are having many epilepsies like SCN1A mutation, SCN2A mutation, which we'll see in the further slides. The third one is the age-specific response. Now there is one epilepsy which is called CDKL5 mutation. If you start management at the early, you will stop or prevent the disease progression. And fourth one is the precision tailored drugs. Use of pathways or genetic specific drugs, including repurposed agents. Just for example, cannabidiol for Dravet syndrome and quinidine for the KCNT1. So what was the old approach? When we talk about, say, traditional versus precision therapy. So old approach, the anti-seizure medications were based on the seizure semiology. For example, whether it is a focal seizure or generalized seizure. Focal seizure, we tend to give oxcarbazepine, we tend to give eptoin, that is phenytoin. And when it is generalized, we tend to give valproate. In the precision approaches, treatment should be based on gene and the pathway mechanism. Old approach is little bit on the trial and error therapy, and here the precision approach is very targeted of and use of the approved drugs. Now let's go to the cases. Now, my first case is a 10-month-old female child who had normal perinatal and family history. She had onset of the seizures from 5th month of the life. Those were polymorphic seizures, tonic, clonic, atonic, myoclonic, variety of the seizures. MRI brain was essentially normal and EEG was showing multifocal epileptiform discharges. So this girl child, she had drug refractory epilepsy. She was on polytherapy for the same, and obviously she was not suitable for the epilepsy surgery. So currently the child was treated with oxcarbazepine, phenytoin, and the clobazam. Current seizure frequency was almost 30 to 40 seizures per day with poor quality of life. Now here we went straight ahead with the genetic testing. We got her whole exome sequencing, and we observed to have the SCN2A gene mutation, which was a loss of function variant. And here, when there is loss of function variant, and if you are giving sodium channel blockers like oxcarbazepine and eptoin, that will affect child very negatively. So we tapered and stopped oxcarb and lacosamide. We have started on levetiracetam. After 15 days, there were no seizures and the sensorium of the child was improved. So consider genetics very early on in epilepsy, specifically drug refractory epilepsies, that to channelopathies, for better optimization of anti-seizure medications and precision therapy. Now, this is position paper of International League Against Epilepsy on treatment of seizures in the neonates. What are the guidelines? If you see, it is very much gene related. Now, if we find the particular neonate is having seizures, tonic seizures, myoclonic seizures, and we rule out the common conditions in the NICU. For example, sepsis, we rule out hypoglycemia, the common, as I already told, the common things are commonly correct. Then you go for the genetic approach. Now, if you find the KCNQ2 mutation, use sodium channel blocker. If there is SCN2A mutation, the baby is less than 3 months old, it is likely to have a gain of function mutation where you give sodium channel blockers. If the seizure onset is more than 3 months, early infantile, it is likely to be a loss of function mutation. You avoid sodium channel blockers. If it is SCN8A mutation, you give high dose of phenytoin and you avoid levetiracetam. Levetiracetam is being very excessively used in all the circumstances, like the wonder drug. So here in SCN8A, you are supposed to avoid levetiracetam. So as I told you, SCN1A, SCN2A, SCN8A, different genes. And having the precision therapy, SCN1A Dravet syndrome, avoid sodium channel blockers, give valproate, give cannabidiol. You can add stiripentol. However, we do not give stiripentol, as well as the fenfluramine. SCN2A gain of function, sodium channel blockers is the management. SCN2A loss of function, avoid sodium channel blockers and start the supportive therapy. SCN8A gain of function, you can give sodium channel blockers. And in loss of function, generally supportive therapy is enough. So there are other genes also where the medication is available. For example, ALD7A1, where the pyridoxine is the treatment. KCNQ2, sodium channel blockers. SCN2A, sodium channel blockers. BP1, that is the severe form of epilepsy in neonates, which is called Otara syndrome, where you can give levetiracetam, vigabatrin, and valproate. And SYNGAP1, where you can treat with valproate and naloxone. So precision is not just knowing about the gene, but it's all about what the mutation is doing. As I already told, whether it is gain of function mutation or loss of function mutation. Why this matter? Because the same gene, for example, SCN2A, completely having different drug choice depending upon the gain and loss of function. Phenytoin can be life-saving in gain of function, but disastrous in loss of function mutations. Coming to the other disorders apart from epilepsy, for example, hypermagnesemia, Niemann-Pick disease, cerebrotendinous xanthinosis, dopa-responsive dystonias, and paroxysmal kinesogenic dyskinesias, we are having precision therapy in our hand. So this is our own experience at D.Y. Patil Medical College and Research Center. It is the paper on phenotypic and genotypic spectrum of development and epileptic encephalopathies. It was a retrospective observational study, and we observed so many genes affecting these children where the medication is available. Coming to the another case, she's a 2-year-old girl child with history of multiple episodes of behavioral arrest. Now here you tend to make absences. No, absence is epilepsy syndrome. So if the child is just stopping for a while, you can tell whether the child is having a hypomotor seizure or whether the child is having behavioral arrest. Blank staring spells 10 to 20 per day and motor delay. Her perinatal and family history was normal. Examination was normal. EG was showing infrequent frontocentral intraictal discharges. So she had little atypical and early onset absences, you can say. Now, less than 4 years of age, absence epilepsy, very uncommon. Or young child, less than 4 years, having these hypomotor seizures, behavioral arrest, or absences, think about something else. So we got her MRI, which was normal. CSF parents, they did not consent for the same. So we have planned whole exome sequencing. And whole exome sequencing showed SLC2A1 mutation, which is GLUT1 deficiency syndrome. And here, the management is very simple. So what happens in this GLUT? So GLUT1 is the major glucose transporter expressed both in brain endothelial cells and erythrocyte. So the management is just ketogenic diet. So etiology known, it is the monogenic defect in SLC2A1. Mechanism, decreased glucose transport across blood-brain barrier, which leads to decreased cerebral energy. What is targeted therapy available? Ketogenic diet, which bypasses glucose dependency with ketone fuel, and outcome being improved seizures, alertness, motor function, and the cognition. So you have to consider early genetic studies in this case. Generally, if the parents would have consented, then the cerebral sugar, that CSF sugar, would be on the lower side. Another case, a 12-year-old male neonate with refractory seizures since day of life 1. Multiple anti-seizure medications were tried without effect. EG was showing burst separation pattern. CSF was normal. No structural abnormality on MRI. And seizures stopped dramatically after IV pyridoxine. So this is the pyridoxine dependent epilepsy. It is a vitamin dependent epilepsy. When the baby is not responding to your first line anti-seizure medication, if the baby is less than 6 months of age, then always consider vitamin dependent epilepsies. The management is very simple. Just give IV pyridoxine under controlled environment. Otherwise, there is always chance of development of apnea. So give pyridoxine 100 mg IV, the seizures will be subsided. So high dose of oral prednisolone 30 to 100 mg per kg per day lifelong is the precision therapy. You can add arginine and lysine restricted diet in long term, which will reduce the toxic metabolites. Avoid folinic acid, which can worsen seizures in pyridoxine-dependent epilepsies. Similarly, there is pyridoxine 5-phosphate oxidase deficiency. The clues: neonatal seizures not responding to pyridoxine, European pyridoxine, and it responds only to pyridoxal 5-phosphate, which is again confirmed by the PNPO mutation, and therapy is pyridoxal 5-phosphate. Pyridoxal phosphate in the range of 30 to 60 milligram per kg will take care of the seizures. Similarly, there is biotinidase deficiency, folinic acid responsive seizures, MTHFR deficiencies, glutaric aciduria type 1, and cerebral folate deficiency, where you can give targeted medications to the children. Coming to the next case, a 4-month-old girl present with onset of seizures at 5 weeks of life, tonic myoclonic seizures resistant to multiple anti-seizure medications, severe hypotonia, poor eye contact, feeding difficulty, EEG showing multifocal spikes, background slowing, MRI showed little delayed myelination. The genetic test showed CDKL5 mutation, and the precision for the same is ganoxolone. Okay, so it mainly affects females, early onset epileptic encephalopathy with severe developmental impair, where you can stop the seizures early and make the child better. Now coming to another case, a 10-month-old male presents with seizure onset at 3 months, multiple seizures, tonic, atonic, myoclonic, significant hypotonia, poor visual tracking. EEG showed slow background, multifocal spikes, MRI cortical atrophy with delayed myelination. Genetic testing showed green2B mutation. Now this green2B mutation, it is like developmental epileptic encephalopathies where memantine is the precision therapy. So these are the genetic developmental encephalopathies where precision therapy they are emerging. For example, CDKL5, already ganoxolone is there. Green2B, memantine is there. PCDH19 epilepsy, I would like to emphasize more on this one. This epilepsy is very particular. Now we here in pediatrics that you must have heard about Duchenne's muscular dystrophy, where the male they manifest the disease and the women they carry the particular affected gene. In PCDH19 epilepsy, the male they carry the gene and female they manifest the disease. So you are finding a girl child with multiple seizures, unresponsive to your routine medications, little developmental delay. Think about PCDH19 and what is the treatment? Low dose steroid or stiripentol. You give these female kids and they will become seizure free. STXBP1, SINGAP1 I have already talked. Similarly, SLC6A1 and FOXG1. There are right now supportive therapies, precision therapies are emerging. MECP2, Rett syndrome, devastating disorder in pediatrics. There is regression of milestones in the girls with hand breathing movements. The precision therapy has arrived for the same and it is trofinetide. So it is FDA approved for the Rett syndrome. The second one is the GINA1, where the child presents with severe form of dystonia, twisting movements, where the deep brain stimulation will be the treatment. Now, not only say you should have genes or something, if you know what the syndrome child is manifesting. For example, West syndrome, you can directly go ahead with ACTH, vigabatrin, and mTOR inhibitors if there is tuberous sclerosis. Lennox-Gastaut syndrome, severe form of epilepsy, where there is management with the cannabidiol, rufinamide, fenfluramine, and ketogenic diet. DUS syndrome, again ketogenic diet. And Dravet, I have already told you how to avoid sodium channel blockers. You can go ahead with stiripentol, cannabidiol, valproate, and fenfluramine. So tuberous sclerosis, the genes affected TSC1, TSC2, where you can find little adenomacylation, chagrin patch, multiple hypopigmented macules on the body. Think about tuberous sclerosis. And here is the pathway, the mTOR signaling, where you can block that pathway by giving everolimus or sirolimus. Now, the genetic part of the epilepsies I have covered. There are few ITs, which are the infection triggered epilepsy syndromes, which we find in pediatric age group. And again, very devastating. One is the FIRES, that is the fever-induced refractory epilepsy syndrome. Autoimmune epilepsy is Rasmussen's encephalitis, acute necrotizing encephalopathy. Now, if the house is open for the same, now the prognosis of FIRES of ANAC was very devastating. But nowadays, when we diagnose a child having FIRES and we do CSF IL-6 levels, if the IL-6 levels are increased, we start giving tocilizumab with the good outcome. Similar things we do in ANAC, we go ahead with tocilizumab very early in the disease along with the steroids and IVIG. Rasmussen's encephalitis, yes, early on you can give IV steroids, IVIG, and later on the hemispherotomy is the treatment. Now coming to the neuromuscular cases, he is a 4-month-old male, term, normal delivery, non-lifting head, severe hypotonia, weak cry, feeding difficulties, tongue fasciculations. There were no dependent reflexes, EMG are showing denervation potential. So when you are finding a hypotonic child who is alert, without reflexes, tongue fasciculation, your clinical diagnosis is spinal muscular atrophy. You have to get multiple ligation probe assay, that is MLPA. Early on, initially we used to do PCR, but now MLPA we find the duplications, deletions in the MLPA, and where we found the homozygous deletion of SMN1 gene with 2 copies of SMN2 gene. So this is SMA type 1, which is autosomal recessive condition, where there is denervation of anterior horn cells. There is type 0 also, which you can find in utero. And what are the targeted treatments for SMA now? Even though they are very costly at this point of time, however, there are medications for the same. Initially, it was said that, no, you just watch the death of the child. If the child is having SMA1, he will never see it and he will succumb at the age of 1.5 to 2 years. But now we are having nusinersen, we are having osmosinogen, that is Zolgensma, and we are having risdiplam. In Pune, we have given this osmosinogen, Zolgensma, to 2 kids. Now the cost is the very prohibitive factor at this point of time. Zolgensma cost almost 16 CR. So here in Pune, we had given by corporate social responsibility to 2 kids and 1 kid. Now after 1 year of giving osmosinogen, that is Zolgensma, is achieving some milestones at this point of time. And second baby, we could not salvage that baby. The similar one is the risdiplam. If the child is having SMA2, you can give oral form, which is the oral splicing modifier, which is on the daily basis, and it is also very costly affair. However, there is precision therapy for SMA at this point of time. Coming to the another disorder, it is the Duchenne's muscular dystrophy, where I already told that the male they manifest, the female they carry the gene, and it is the biggest gene. It is very common clinical scenario. 1 in 3,500 to 1 in 4,000 kids, they do get Duchenne's muscular dystrophy. Now here initially the people used to get muscle biopsy, but nowadays again upfront we go ahead with CPK-NAC. If CPK-NAC is elevated, we go ahead with MLPA, and in MLPA you can get the deletions of the exon. So there are variants out of 1 to 79. There are many exons those are deleted, but in exon 51 deletion, 53 deletion, 45 deletion, we are having now targeted therapy for the same. Even at Ahmedabad, there was the clinical trial which was going on, the study which was going on, and it was all about Ataluren, that is the eteplirsen. Similarly, for exon 53, it is the Viltolarsen, and for exon 45, it is Casimersen. The gene therapies are there emerging now for the large deletions. This is the interesting case. If you can see the child who is having ptosis, so he's a 2-year-old boy with history of perinatal suspected perinatal asphyxia. Now, whenever we say the child did not cry after birth, perinatal asphyxia, we directly to say it is MRCP. But there is no MRCP. Always the history is very important in pediatric neurology. So the child had query perinatal asphyxia, delayed cry, and the child also required 1 week of an ICU stay, and he presented with global developmental delay, recurrent respiratory tract infections, failure to thrive. He had ptosis, nystagmus eye movements, hypotonic baby, having hyporeflexia, truncal and neck flexor weakness was noted. This again picture we took by the consent of the parents. RNS study, repetitive nerve stimulation is sometimes very inconclusive in pediatric age group. The children, they are very, they are not cooperative for the same. MRI brain was normal. We planned whole exome sequencing. So all developmental delays are not MRCP that I want you to tell at this point. We got his genetics. It was showing SCN4A mutation, which was autosomal recessive, and it deals with the congenital myasthenic syndrome. Now here, there is the role of reverse phenotyping. We found SCN4A gene. We are having the phenotype. The child is having ptosis. The child is having hypotonia, decreased reflex. So he was behaving in the form of congenital myasthenic syndrome. Now, when you find congenital myasthenic syndrome and we are having SCN4A mutation, where we can fit this child. We have treated this child with pyridostigmine and acetazolamide, and the child improved. The first two pictures were before treatment and the two are after treatment. Now, why this? SCN4A is important to know. So if you see the congenital myasthenia, if it is DOX7, POLQ and slow channel syndrome, you avoid pyridostigmine. And if it is rhapsine, acetylcholinesterase, SCN4A, then you start pyridostigmine. If there is SCN4A, you have added acetazolamide for the child and the child become better. So if we would not have the genetic mutation underneath, we have treated with invariably with pyridostigmine. And if the child would have POLQ or DOX7, the child would have worsened. So that is beauty of getting genetics in congenital myasthenic syndrome early on. So consider genetics early on in treatable neuromuscular disorders, especially congenital myasthenic syndromes. Call regarding to start pyridostigmine versus salbutamol. In DOX7, POLQ, you start salbutamol, while in others, you go ahead with the pyridostigmine. Repetitive nerve stimulation can be painful. The child often might not cooperate, sometimes be subjective, and can also be deferred if there is good genotype and clinical phenotype match, which is the reverse phenotyping. Congenital myopathies and few dystrophies, genetics can be considered early on, can defer the invasive test like muscle biopsy. And as I already said, Duchenne's muscular dystrophy and spinal muscular atrophies, after getting baseline investigation, we directly go for MLPA, that is the multiple ligation provosis. We'll again go to another case Vinit. He's a 2-year-old boy, born of third-degree consanguineous marriage. Parental history was normal. He had motor and cognitive delay. Family history, the sibling had 21 episode of loss of consciousness, altered sensorium, and he had also documented hypoglycemia, also has developmental delay. So this consanguineous marriage is very important in pediatric neurology. 3 types of consanguinity, 1, 2, and 3. Generally, we get type 3 consanguinity, mama ki ladki, bua ka ladka. That kind of consanguinity is very much common in Maharashtra as well as the northern part of Karnataka. While you do not see consanguinity much in Bihar and in Uttar Pradesh and in Rajasthan and Haryana. So when you are thinking about the consanguineous marriage, another child, sibling affected with the similar thing, always think about the genetic disorders. So Currently, this proband is admitted with fever, vomiting, and decreased sensorium. CNS showed encephalopathy, hypotonia. Uh, Abdominal examination revealed 4 centimeter firm liver, and we got his initial workup, which showed the child was acidotic, high lactate, ammonia was borderline elevated, and he had positive ketones in the urine. So it was a perfect match for any metabolic condition in this child. EEG showed low amplitude background, generally it's seen in the encephalopathic patients. And despite the infection being treated, the sensorium was poor, the acidosis was refractory, so continuous renal replacement therapy was done. Neuroimaging, we could not get done because of the hemodynamic instability. So we went ahead with TMS GCMS, that is the tandem mass spectroscopy and mass chromatography. So it revealed 10-fold elevation of 5-hydroxyphenyl pyruvate and 5-hydroxyphenyl acetate, which are the tyrosine metabolites. So with the clinical picture of metabolic decompensation, hepatomegaly, and TMS GCMS report, tyrosinemia was suspected. In this scenario, now the management will be, one is CRRT and second one is the hepatic transplant. However, here we have sent rapid exome sequencing and it turned out to be fructose 1,6 biphosphatase deficiency disorder, which is pathogenic, autosomal recessive, homozygous. We stopped oral foods, we have started uncooked cornstarch, and there was significant improvement, and the child was discharged on the oral medications and special diet. So here, starting uncooked cornstarch was a precision therapy for this fructose 1,6 biphosphatase deficiency. So here in life of the critically ill child and emotions of the parents, they overweigh money over here. Now, here, when we talk about the metabolic disorders, the treatment decisions, those are based on whether to stop the soft diet, to stop the meal, initiation of the uncooked cornstarch, which was very crucial in managing refractory acidosis in our patient. Baseline metabolic workup, ammonia, lactate, venous blood gases or arterial blood gases, urinary ketones, blood sugars are very important dictums in workup. It doesn't mean that you should not, you get them, that is the baseline workup. However, they only help us in delineating or subtyping the inborn errors of metabolism, that is whether it is a amino acidopathy or whether it is fatty acid oxidation defect, but not always pinpoint one etiology. Here, rapid exome sequencing is excellent add-on tool. Neuroimaging, it is a crucial tool, but downsides include timing of the scans, diffusion images or changes, they can fade away in 7 days of acute decompensation. That is the pseudo normalization, and sometimes patterns can be non-specific and overlapping. TMAG, same as I already told, can be non-specific, leaving us sometimes in a dilemma, and also has downsides. For example, when you collect the sample, you can find false positives in liver dysfunction and in drug ingestion. And these are few, the references for the same, where you should always think rapid exome sequencing in the setting of a sick child where there is consanguinity, another child is affected, metabolic decompensation. You can definitely go ahead with rapid exome sequencing. So my take keyways from this talk. The precision therapy is already in clinical use. As I already told, it is Zolgensma, nusinersen in SMA, then everolimus, sirolimus in tuberous sclerosis, ketogenic diet in GLUT1, Dravet we are giving cannabidiol, CDKL5, ganaxolone. So diagnosis must go beyond the gene. So identifying whether it is gain or loss of function mutation. Therapies now include antisense oligonucleotides, gene therapies, mTOR inhibitors, cytokine blockers. Just like tocilizumab and anakinra, you can give in FIAS and ANIC. Early recognition and genetic testing are critical, even if therapy is not immediately available for the same at this point of time. And clinicians' role is to suspect early, test smart, and guide towards the right therapy. In India, awareness and accesses, they are growing. Now the cost of whole exome, clinical exome has drastically came down. However, clinical judgment remains the key. Common things are commonly correct, but in the given setting, you can always go for the precision medicine. So, so it is not the luxury of being, the precision therapy. It is not the luxury. It's very important. So it is the one mutation, one diagnosis, one chance to change the child's life. Precision therapy is the new era in pediatric neurology. Thank you.
Thank you. Thank you, Dr. Vishwanath. You may stop the screen sharing so we can have discussion. That was wonderful. I mean, you are really like Karna, no? You could see the arrow in the eye. The presentation was as precise as the title of the talk, the precision therapy. Wonderful. We learned a lot, and I invite Dr. Sridhar Joshi to conduct the question answer session with his own comments. Dr. Sridhar, please come in. Yeah. Dr.
Yeah,
Sridhar is a pediatric neurologist based in Baroda. He was trained at CMC Vellore, and we had him as a guest speaker earlier also in our Saturday club. So over to Sridhar.
hello, good morning all. So Dr. Vishwanath delivered excellent deliberation on precision therapy in pediatric neurology. And just like he started, like if you see a decade back, all the cases he showed you, you would have not have believed that these all cases would have been treatable or been even managed. The parents would have been given an answer that this is all we can do, and then rest is up to whatever supernatural force they believe in. Okay, but with the advent of genetics, now the precision therapies are coming. So this is, I think, a win for science because genetics came and the scientists researched those pathways. We know how to change those pathways via medicines. So when we say precision medicine, the precision medicine in pediatric neurology has grown leaps and bounds. Similarly, we have precision medicine in other fields also, like in oncology and renal medicine and all those things. But in pediatric neurology, it has grown leaps and bounds because of the advent of genetics. For practicing pediatricians, the main point to be understood over here is majority of these cases, the opportunity is in early age. The infants with unexplained epilepsy, the infants with unexplained neuromuscular disorders, these are the ones who have positive family history, the ones who have previous sibling deaths. If you have all these case scenarios in your history and examination, then do early genetics. That is the main theme which Dr. Vishwanathan highlighted. So if you consider, let's say, the initial first 5 cases were based on epilepsy, all of those children were less than 5 years. Majority had no usual causes of seizures like dyslexia, hypoglycemia, or any structural malformation or any meningitis. So once those basic causes are ruled out, you should go for early genetics. That is the key. For two reasons. First, we get a diagnosis, and if the diagnosis is already been having a precision medicine, we can start that, and that can improve the child's quality of life significantly, curing the epilepsy. And second, even if the precision diagnosis is not available, we still have the diagnosis and we have a chance to do a genetic counseling. What is the chance in second pregnancy if the parent wants to have a normal child? So, for both of the reasons, for medicine diagnosis and treatment, you require early genetics. Then the sixth case which Dr. Vishwanathan talked was on SMA. You might be seeing a lot of advertisements on Facebook and Instagram that my child requires therapy. A lot of crowdfunding sources ads are coming. So SMA, DMD, all these treatments were not available, but now are available. Although the cost is prohibitive, but still with crowdfunding and such other sources, it is becoming a reality nowadays. And then there are clinical trials. So currently also in CMC Vellore, we have a trial going on for DMD, where we give intravenous etiplirsen for exon 51 skipping deletions in DMD. So Same way as in CMC Vellore, AIMS, PGI Chandigarh, RIC and Ahmedabad, just 100 kilometers from our state of Vadodara, we have all these therapies available. But what is important over here is awareness that these therapies are available. So this awareness can be reached to fellow pediatricians and fellow physicians only if such great meetings are conducted as we are conducting. And actually, I feel that this should be advertised. The only reason it is not advertised that much is because these clinical trials is limited patient capacity. So, like let's say in CMC Vellore, we can only take 8 patients per institute for this multicenter trial. So, if we just give advertise, people from all over the country will start pouring in, and it will be difficult to manage the trial. But I think with the advent and with the increasing availability, the therapies would come in action. Third thing which I felt is in acquired disorders, early imaging is the key. Like Sir discussed the case of infection triggered encephalopathy syndrome, which is known as acute necrotizing encephalopathy of childhood. Now, this patients present with acute encephalitis syndrome, that is fever, seizures, and altered sensorium, and they have deep coma. You treat them with our usual protocol like ceftriaxone, acyclovir, maybe antimalarials, but they don't respond. Had imaging been not been done in this case, we would have been still be giving a empirical ATT and stuff like that. But if you do imaging in this case, and if the imaging shows a trilaminar necrosis of thalamus with involvement of white matter and brainstem, that is classical for ANEC, that is acute necrotizing encephalopathy of childhood. And as soon as you see a trilaminar necrosis of thalamus, the buck stops there. You stop your antibiotics and antivirals, and you give steroids and tocilizumab, and post that you achieve a survival-free outcome in majority of cases up to a tune of 50 to 70%. But had imaging not been done, it would be impossible. So I do agree that because of hemodynamic instability, majority of times we do withhold imaging. But for this acute encephalitis syndrome cases, try your maximum. Even if the child has to go on a ventilator with a resident, it has to be done because it saves the child from unnecessary therapeutics and gives the child a precision therapeutics. So that is important. So all in all, a wonderful presentation with cases in all the realms of pediatric neurology, congenital, genetic, metabolic, and acquired with neuroinflammatory and immune-mediated etiologies. So it was a great talk, and I open the house for discussion.
Thank you, Dr. Sridhar. We have Dr. Baldev Prajapati with us, Dr. Jagdish Chinnappa with us. Your comments are welcome, Dr. Prajapati and Dr. Jagdish.
Excellent presentation by both of them, outlining what are the current thinking on precision medicine. I am reminded of a very interesting book which I read many years back. This is by Eric Topol on the creative destruction of medicine. And there he talks about basically how medicine is moving towards personalization and individual therapy. What I wanted to ask a couple of questions were, one is, in addition to diagnosis of a condition through precision medicine, therapeutics also has precision implications. Like, for example, drug handling by patients is very different. Some patients with a very low dose of a drug may land up with toxicity, and some people can tolerate very high doses of drugs. So, how does the genetic makeup of an individual is important in drug monitoring in children with epilepsy? This is the first question I have. The second comment I have is on the use of tocilizumab, which was mentioned for immune-mediated encephalitis. There is an interesting program in the third week of April on cytokine storm syndromes in pediatrics, and this can be, I think, this is also available online. If anybody is interested, they can join in. And we have been doing this program for the last couple of years, especially after the COVID-induced problems. And we now know that the large number of various disorders, including complications after dengue, are basically immune-mediated and are responsive to specific IL-6 inhibitors like tocilizumab, etc. The third point I want to mention is that supposing you have a disorder, for both the eminent neurologists in the panel, supposing you have a disorder like, for example, I have a patient with congenital myasthenia, where all genetic studies done in India and in Singapore are negative, then what do we do? are we justified in starting salbutamol, or are we justified in trying physiostigmine? How do we progress in such situations? Because I have a couple of patients right now who have probably genetic syndromes but are not detectable by the current methods of testing. So what do we do then? And last point is, large number of the SMA DMDs, there are ethical issues involved in how you're going to choose the patients for clinical trials. I think we need to see that, even after the trial, there is post-trial access to these medications, how these are given by the companies. These are things that we need to look at. It's a whole Pandora's box of ethical issues in clinical trials for these conditions. So these are some of my comments.
Yeah. So can I take on few questions, Joshi sir?
Yes.
Now here the second question is very interesting. All questions are fine. The question number one I will keep for Joshi sir regarding the individualizing the medication, the precision medication, because many of the kids they respond differently to the particular medication, small dose or high dose, and whether the precision therapy is having its take on that, it needs to be studied on a larger scale. Number one. And whenever we start with the small dose, and then depending upon the clinical condition, we escalate the dose. That is number one. Number two, the tocilizumab, what we are finding in MA, as well as in few cases of fires, here at DY Patil, we are going directly within the say first 24 hours or first 48 hours, whenever the child is presenting to us. Even though the child is fulfilling the criteria, the child is encephalopathic, the child is having some tone abnormalities, the child is having brainstem signs, then we are thinking on the lines of NA and we are giving tocilizumab very early on. So what was the initial one? It was the IV methylpred, IVIG, and then tocilizumab. Here we go ahead with CSF, IL-6 level, and if the IL-6 levels are very high, we start with the tocilizumab. Regarding SMA and these questions, sir, it is really right now the cost, Joshi sir has already told, the costs are so prohibitive, and but then it's become very difficult. So we had given this osmosinogen, Zolgensma, to two kids in Pune. One kid is showing little improvement, and the second kid we could not salvage only. The child succumbed after 3 months after giving so costly medication. So it needs to be tried on the larger scale. The moral of this particular presentation that we should keep our eye on precision therapies. So it will enhance our diagnostic yield, our prognostication, genetic counseling, and so. Joshi sir?
Dr.
Yes,
Saida.
sir. Yeah. So for the first question, the answer in one word, if I have to give, that is known as pharmacogenomics. So each and every individual has unique metabolism capacities of liver and the organs which metabolize the drugs which are given to the system. So we all know of cytochrome P450 enzyme systems. So their activities are different in different individual, which determines the ability of the child to respond to a particular drug. This is particularly seen in epilepsy. If I have to give a corollary, you can think of antibiotic resistance. Okay, some of the organisms develop P glycoprotein, and the drug is thrown out of the organism's cell and they develop resistance. Same way in epilepsy, if the enzyme which is metabolizing the drug is hypoactive, the child will have toxicity. And if it is hyperactive, then the drug will be metabolized and the child would have a poor efficacy of the drug. So the answer for it is pharmacogenomics. How to know that? I will give you some examples. So in CMC Vellore, what we used to do, there are certain drugs like lamotrigine, carbamazepine, oxcarbazepine. They are prone to drug-induced rash and Stevens-Johnson syndrome. So we used to do HLA-B15 O2 phenotype and HLA-B31 O1 phenotype in these cases before starting carbamazepine, oxcarbazepine, or lamotrigine. And if they were positive, we would avoid these drugs. They are not 100%. Even if they are negative, they could have the rash. But if they are positive, the chances go as high as 80 to 100%. So this is what is known as preemptive pharmacogenomics before starting the drugs. Second thing is, after starting the drug, if the response is not adequate, first of all, we will see whether the drug is appropriate for that epilepsy syndrome or not. If it is appropriate and if the child is not responding, then we will do pharmacogenomic studies and then find out whether the enzyme affecting the metabolism of the drugs are hypoactive or hyperactive, and based on that, then we would change the drugs. So there are conditions in which uh, some of the drugs are not effective in a milder dose, but when we increase the dose, they are effective. So this is the second point. Third point is precision-based therapeutics. So in normally, phenytoin maintenance dose is 5 to 10 milligram per kg per day. But if you have a condition like SCN8A related developmental epileptic encephalopathy, the maintenance dose of phenytoin which has to be given should go up to 20 to 40 milligram per kg per day. So knowledge of precision medicine, precision genomics is required to give a dose. So an SCN8A given a 5 to 10 milligram of kg for phenytoin, and you'll always think that the child is not responding. So when you have SCN8A, you have to give a high dose of phenytoin, and then only the child will respond. So these are the few points on pharmacogenomics about the first question. Second is cytokine release syndromes, which sir is talking. In that, if I have to give a clinical clue, the clinical clue is if you have coma within first 72 hours of a febrile encephalopathy, it's usually a innate immunity dysfunction. And innate immunity dysfunction are usually associated with cytokine storms. So increased cytokines like interleukin 1, interleukin 6, etc. And so the drugs are anakinra, tocilizumab, etc. Whereas if it's a disease which is acute onset, that is encephalopathy or a deficit occurring within 3 to 7 days or after 7 days, it's more acquired immunity dysfunction where you have drugs like rituximab which are working because these are mostly antibody-mediated disorders. So a clinical clue will be, as sir told, if you have a febrile encephalopathy with coma and brainstem signs within 72 hours of presentation, then think of innate immunity dysfunction, give early steroids plus tocilizumab. And if that thing is occurring in a 3 to 7 day or 7 to 10 day, then think of antibody-mediated disorders, send appropriate tests like MOG, NMD receptor antibody, and start early rituximab in those cases. So this is for cytokine release syndrome. For congenital myasthenia, our protocol in CMC was any congenital myasthenia, we try to do RNS if possible. If not possible, we do give a pyridoxine trial in inpatient department to see whether they worsen or not. If they do not worsen, then we continue with pyridoxine. But if they worsen, we stop pyridoxine and give a trial of salbutamol in those children. With salbutamol, if they improve, okay. If not, we add on acetazolamide in those children. So this is how we go. Mostly the whole exome sequencing would have been done for the child what Jagdish sir was talking. But the genes change over time. We can do reanalysis and we can also do something for a whole genome sequencing. If not, Mayo Clinic has a very good doctor by name of Dr. Sitara Ramdas. She is of Indian origin. We can discuss the case with her. Dr. Sitara Ramdas, she is a congenital myasthenia expert, and she can guide further regarding genomics of the child for congenital myasthenia and the further treatment. But having said that, before that, a trial of pyridoxine in inpatient department, if not working, then salbutamol and acetazolamide should be tried. And post-trial access is a large ethical issue which needs to be addressed, but I think that would also be done in future once the medicines are available more frequently and the cost of R&D is recovered and the medicine cost will decrease. But till then, we do have some hope for these children. So these were my few comments.
Thank you. Very precise answers. I mean, both of you have been wonderful. Dr. Baldev, your comments?
Good morning, friends. I think there is no scope of comment. Both of them really, Dr. Vishwanath and even, I will say, moderator, Dr. Sridhar, provided a lot many informations to all of us general pediatricians. And I think we'll have to just realize that now the scope is there beyond our basics understanding, and we can utilize it with the advanced understanding of the science. I remember that we have the pediatric neurologist. Probably last year or so, we had some multiple cases where probably we were lost with some convulsion and we don't have the answer. As you say, that sugar and calcium and magnesium and even the infection and everything is not suggesting any reason. Then we took his help. And frequently he was going for this I will say, exome sequencing study or different type of genetic study. And initially we had this, that really these new advancements, how much we know and really guiding us or really creating confusion to us. But we noted in 5-7 cases that some absolutely new conditions, which probably we never thought of, even not knowing, and even few, not all of them, but few responded very well the therapy what they suggested. And then we realized, yes, I think this science will have to learn in the details. One patient, I think I even contributed with our pediatrician friend that we repeated infections and we said that it is some immunity disorder. We got even the chronic granulomatous disease. One of our students even did the poster presentation. And later on genetic study we got that was the ataxia telangiectasia. There was no ataxia at all. And that was my, I will say, basic understanding that if there is no ataxia, how we can think it. I asked the child to come back in the follow-up and I examined the details of the eye. There was even this telangiectasia in the eye. So I think that that's the thing which we'll have to learn. And Dr. Satish Bhai, with this understanding, one, we have the new batch already posted for the MD Pediatrics. Yesterday only with this discussion to one of my postgraduates with the consultation of our neurologist and even our authority, we had decided to go for one dissertation on this genetic study in the neurology because we have the pediatric neurologist coming regularly to our institution. And I'm sure that we'll learn with this, and I take the liberty of both the neurologist, probably Sridhar is nearer to us, of course, Vishwanath also, that this student may bother you because we'll have to learn that how to study along with the help of our pediatric neurologist at our institution. And certainly so many things, with the basics, as you said, that once we come to know that now we don't have the very precise answer. And some of the clues are there, clinical clues. From that, I think if you go for this type of the advanced science, certainly we can learn and even we can help them. Now we know that Satish Bhai, we have changed our post-graduate teaching. The cerebral palsy, not necessary child cried and didn't cry, is not important what we were taught. And cerebral palsy, what we say, it's a Down syndrome or condition. Many of them, which may turn out to be even these neurological other disorders. And certainly, I think thank you very much for at least a message from Satish Bhai. I know, but this morning I was difficult to attend, but I think it was really interesting and worth for me to attend. Thank you very much. Thank you
for attending because this was going to be very interesting. I was very sure about it because I heard Dr. Vishwanath at Pedicon and I made up my mind that time only that let us have him more often to a larger audience here. That time he had only 20 minutes to talk, but it was so good. And about Vishwanath and Sridhar Bardevai, they are very approachable.
Yeah.
Very, very approachable. So your students should not have any issues approaching them. So Dr. Vishwanath and Dr. Sridhar, both of you, thank you so much for sparing your time. And of course, Dr. Jagdish, Dr. Baldev and others who have joined and remained till the last moment. So thank you all. We meet next Saturday again. Again, a very interesting talk by geriatric specialist, Dr. Anand. Next week, we'll have one more interesting talk. So thank you all. See you all. Thank you.
Thank you, sir. Thank you.
Thank you, Dr. Pandya. Thank you, Dr. Pandya, for all the effort. And thank you, Dr. Vishwanath and Dr. Sridhar. And of course, Dr. Baldev. Dr. Baldev, I think from next time on your clinical rounds, you should have a genetics expert along with you.
So it was a really great morning with Baldev sir, with Pandya sir, Jagdish sir, and dynamic Sridhar sir. So thank you, sir. Thank you for this opportunity.